Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN. Healthy you, healthy nation, healthy world. I'm Nancy Valentine, PhD and registered nurse. And this show is dedicated to you, the healthcare consumer. And I have 2 marvelous guests today that are going to talk to us about a very interesting topic on patient advocacy. And I just want to tell you about patient advocacy in general. It is a term that can have many definitions. For instance, you may have heard of the American Cancer Society or the Alzheimer's Association. They are often considered advocacy groups. But the focus of our conversation today is really meeting 2 clinicians who really forged a path of becoming advocates themselves. And they're going to tell us about their journey, and they're also going to really educate us about the role of advocates, and that's going to improve your health care. So the topic today and our title is Advancing Patient Advocacy. These 2 nursing emeriti professors were forging their path, and they're going to tell you about it. So let me introduce both Dr. Connie Carino, and Dr. Arlene Holden. So let me tell you a little bit about both of them. Dr. Carino has a broad experience including higher education, hospital administration, nonprofit executive and founder of organizations, and has worked as a consultant. She is a psychiatric nurse by training, and in that role, with that particular background, she worked as a clinical director of psychiatric nursing, and she was the interim clinical director of medical nursing at the Hospital of the University of Pennsylvania. In this case, where she had that role, she was responsible for the nursing care of patients in 400 beds of that hospital. She also started the nursing liaison service so that psychiatric nurses could go out and do consultation throughout the organization, and she has held joint appointments in nursing and medicine at the University of Pennsylvania. Welcome, Connie. And her colleague, Dr. Arlene Holden, is a graduate also of the University of Pennsylvania and Temple University, where she earned her PhD. Dr. Holden is currently the founder and executive director of HEAL, H-E-A-L, which stands for Holistic Enrichment of Adult Living. It's a nonprofit home care agency located here in Bryn Mawr, Pennsylvania. In her most recent position, though, Dr. Holden was the director of nursing of palliative care services in Philadelphia at the VA Medical Center. For the past 20 years, she was a member of the standing faculty clinician educator at Penn. And while at Penn, she also was the director of the Adult Oncology Nurse Practitioner Program and serves as psycho-oncology consultant to the Abramson Cancer Center. So both of these women are extremely distinguished. That's why they're professors emeriti, and they have a vast career in this area. And when we think about advocacy, one of the things I would just say is that most people don't wake up one morning and just say, I'm going to be an advocate, a patient advocate, or a nurse patient advocate. It is an evolving journey, and I think that that's where I'd like to ask the 2 of you to really start with this discussion. How in your early lives as nurses, tell us about how you became more aware of the role of advocacy and how that really influenced your career.
Well, I think for me, Nancy, it was having the beginning experience in psychiatric nursing. Because in that preparation and in that training, one learns to listen in a very unique way. And so it's a matter of education that informs inquiry. And it's a way of dealing with people that isn't in a perfunctory manner, in a practical manner. It's really beginning to look at the human being as a whole person. And that was very important to me in my baccalaureate program. As a matter of fact, I was part of an experiment in change where way back 100 years ago, they began to integrate psychological concepts into the curriculum. And so, I took that very seriously, and had that training, so to speak, because when I was an undergraduate, we, in the psychiatric part of the curriculum, we really had to delve into why people behave the way they do, making interpretations. And so while it becomes very intuitive when you're dealing with people, it really has a very strong educational foundation to it.
Well, I mean, every nurse would say that they're a patient advocate on some level. But you took advocacy, as we will learn more, to a whole new level. And I think that we'll discuss that. But Arlene, in terms of your early leanings towards advocacy, where do you think it really piqued your interest?
So as you ask that question, Nancy, I see the faces of 3 patients, Marie, Bill, and Marianne. And those patients, each in their own way, touched me so deeply that I felt, I'm using Pat Benner's definition of advocacy, walking alongside your patient and removing obstacles. So these 3 people, all very ill with various diagnoses, from cancer to cardiac disease to end-stage pancreatic cancer. And walking their journey, seeing the difficulties in having their voices heard within the system, being able to make decisions without feeling guilt because they perhaps thought, this drastic treatment is creating more problems than it is giving me a quality of life. So being able to have their own voice, to stand up to not only the physicians or the healthcare providers, but also to their family members, to say, these are my wishes. I need them heard. I need them respected. And I found that my role was critical with them, to be able to support them, enable them, and give them voice to the people that mattered the most so that their wishes could be honored.
And how did you do that? Can you just tell us, some of the detail of what that entails?
So forming that therapeutic relationship, first of all, and I am a psychiatric nurse as well, so the art of forming the relationship, getting somebody to trust me, and then listening to each of their stories, understanding what values sort of have framed their life, what's important to them, what are their preferences, and gradually, like one of my patients, Marianne, and I still remember her saying this, is if I cry in front of my family members, they yell at me because they say, I'm giving up, I'm giving into negative emotion, and this cancer is going to kill me. And she said, I can't even be honest. I can't share my deepest emotion with the people that are the closest to me. So to have me as her sounding board and to normalize, you're human. Of course you're upset. If you were happy you had cancer, we would be worried. And then we talked through that and empowered her. And I actually sat with her in a family meeting so she could tell her family what she needed to tell them. And that actually became a turning point. And then together we could go to the physician and the medical team to say, these are Marianne's wishes. She no longer wants to continue with such aggressive treatment. Quality of life is more important than quantity at this point.
So knowing that the basic, level setting was education, as nurses, I think every nurse gets some clear understanding that their role is to really help translate care for patients, help them migrate through the healthcare system, help them deal with the kinds of problems that you just mentioned. But then when you get back out into practice, tell us about not just some of the patients that you just talked about, Arlene, but some of the systems that you came upon. And how did you build systems that really were then more sensitive to advocacy?
Well, for myself, when I came to Penn, particularly to the hospital of the University of Pennsylvania, it was really the beginning of new thinking about end of life. Do not resuscitate orders. And physicians in particular were so afraid that that meant abandonment of care.
And tell us about the era that you're talking about.
Well, I came to Penn in the 80s.
Okay.
And so it was really the age of the intensive care unit. Okay. And so the problems that immediately emerged was patients being in, particularly the medical intensive care unit, for so many months. And so then, and things were called hopeless, conditions were called hopeless. And then we first decided, well, maybe we need an organizing body to really have conversations with everybody on the staff. And I had done some work at the Kennedy Center of Bioethics in Washington, D.C., in my doctoral program.
Okay.
And so I said, this university system doesn't have an ethics committee. And so another nurse who was a nurse ethicist and 2 physicians, we said we need an ethics committee, because what we were hearing with the first attempt at writing the do not resuscitate order was it meant abandonment of care. So then we got a group of social workers, nurses. I think we had every professional group we could think of except lawyers, because the definitions, legal definitions, tend to be very rigid. And we saw this as a communicating group on behalf of the patient. But what we were really doing was we would be laying the foundation for advocacy. And that it wasn't going to be one profession in particular. Although in the Nursing Code of Ethics, it clearly states that we are the patient advocate. Okay.
That's interesting, because I've met physicians, certainly in my professional lifetime, that would argue that. They feel that they are the ultimate patient advocate, and that it's really a somewhat of the captain of the ship concept, but that really hasn't been your experience.
No, well, it does and it doesn't, and it's all professionals. You know, nurses complain about physicians being patriarchal, and in many ways, nurses are matriarchal. And so it's really more trying to get the system, because everybody says the same thing, the patient should be the center of the system.
Right.
But we don't know how to get the patient of the system. So if you really begin to place decision making for what's happening to you in the hands of the patient, then you're creating a whole new system. Because how do you begin to evaluate how the patient is making that decision? I really do believe it is in the most important thing in ethics is that you can never violate a patient's right to choose for themselves. And so when they started doing a lot of the work at the National Institutes of Health on informed consent, because how do you know when a patient is really fully informed, the ethics really became interesting. I think it is absolutely the baseline for advocacy.
So, I mean, you were on the cutting edge early on when these discussions started.
Didn't know it, but knew that it was troubling enough because we were getting resistance in the system. And so we said, when you feel that kind of resistance about a do not resuscitate order, you begin to wonder, we have to really study this. You can't just, because the normal reaction is to get resistant back, and where does that get you?
Right. So, I mean, so your contribution was really to be a major player in starting the ethics committee there, and helping to design policies and procedures and educating other clinicians and the team and even patients and families about, you know, what this entailed.
Always, because the very first thing we began to do was to do the ethics consult that your previous guest was talking about, and those consults are but they really are, you can call them ethics committees, you can call them whatever you want. Really what they become are communicating bodies. And ultimately what we found out, which I think is very interesting, is that people only sue when they are angry. And people get angry when they feel that the system hasn't listened to them. So the ethics committee really becomes a communicating body where everybody gets on the same page. Because when you can, you include the patient and you include the family members.
Right, right. So, I mean, understanding that in every hospital situation, certainly things go wrong, even under the best of circumstances. So you found that when there was this clear communication, people had a reasonable idea and understanding of what the outcome was, even if it wasn't what they had hoped for.
Exactly.
Versus feeling as if they were shunned or not communicated with, and their only recourse then is to file a lawsuit.
Exactly, exactly. And you know, the first thing you're ever told when there's a serious illness is there are no guarantees. But when people feel that they've participated in the decisions that are being made about care, then they're not angry, and they remember that the first thing that was said was there are no guarantees.
Right, right. So just being very honest and really opening up that conversation and being, again, respectful of the family and the person who may have the illness, and really drawing them into the process early on.
Right.
We've really heard that from some of our other guests, and that seems to be a pervasive theme, but it's taken a number of decades, and it's still a work in progress to get that idea across. It's not 100% in every area.
Exactly, because there are dominant systems and there are secondary systems, right? And as people have to learn about how you can have complementary professions, complementary systems, you have to work through that.
Right. Well, I think that's a very good, legacy that you were able to achieve. And Arlene, you were telling us earlier, in your bio, that you really did some groundbreaking work at the Department of Veterans Affairs here in Philadelphia. And again, that was one of your many expressions of advocacy. Could you tell us about that?
Yes, so and you had also asked about developing relationships
Yes.
with physicians within the system, correct,
Right.
to sort of enhance and facilitate advocacy. So Philadelphia VA, when I was the nursing director of the palliative care service, and as well at the Abramson Cancer Center when I served as psychosocial oncology consultant back in the 90s and early 200s. The heart of that was building collaborative relationships with physicians and others on the healthcare team. So helping people understand, I'm not going to trespass on your role, but we're both here for the best interest of the patient. So how can we best work together? How can I help you? And both in palliative care and in psycho-oncology counseling with cancer patients, it is where do I fit in this role, and then what can I bring to you to help deliver care at the highest quality.
Now, define your role as palliative care nurse. Not everyone would know what that role is.
Right, so palliative care nursing is actually, it ought to start upstream, meaning it ought to start at the beginning when someone is diagnosed with a potentially life-threatening serious illness. So, for example, a cancer diagnosis or a diagnosis of cardiovascular disease or Parkinson's disease. So beginning to work then around what are the patient's values. Let's talk about sort of advanced planning. Do you have a living will? Do you have a healthcare proxy, power of attorney? What are your wishes? How have you lived your life? How much detail do you want about your condition? And talk about shared decision making, how important it is to be an active participant, but some patients will say, you know what, I don't want to be an active participant. I'd rather have my doctor tell me based on his or her expertise what I ought to be doing. So it's sort of having these conversations, plan for what mode of communication is best for the patient, how active a role they choose to take in their care, which family members or significant others they might want to participate, and then communicate that back to the physician and the treating team. So palliative care will start at the time of diagnosis, and it focuses on symptom management, on support, and on advanced planning.
Very good.
Yeah.
So then how did you translate that at VA?
Right, so then we would sit down and we would have meetings with the treating physician and talk about what the patient's wishes were, what their values were, what their needs were. We would hear what the physician's plan was, say for treatment, what the goals of treatment were, help arrange family meetings where we could have this conversation and make sure everybody was on the same page in terms of moving forward. And then a lot of education around what is this illness? Pancreatic cancer killed my mother in a matter of weeks. Is that what's going to happen to me? So talking about personal experiences with cancer, what their loved ones have gone through, and then helping to frame questions in a very efficient manner, knowing you don't have a whole lot of time to have these conversations with the physicians and the healthcare team. So talking about personal experiences, values, concerns, worries, and having that very open conversation about, you've got options. And it's ultimately the patient that makes the final decision based on their values and their needs. Let's have an open conversation. But a lot of greasing the skids with the physicians before the meeting so that they weren't surprised, so that I could bring information about the values, about their experiences before the actual family meeting would take place.
Very good. Now, both of you feel that nursing really does play a very special role in this. And can you say a little bit more about where you feel nurses are going in this role? I mean, you were both very distinguished early on in really helping to set the stage and to do some program creation. But now that people are more aware of this and they're starting to adopt it, where do you see it going? Where do you see the future of this, especially given healthcare reform, other pressures that are going on? What's your prognosis?
So I won't go that far with prognosis, but what I will say is patient advocacy is the driver of quality care. And I think today with the Affordable Care Act, with much more attention being given to transitional care, like for example, Medicare is now paying, starting in January, for transitional care management, and will soon start paying for complex chronic care coordination. So all of a sudden, these patient-centric models are viable. There are financial incentives, and I think nursing is at the ground level of this.
That's a very good point. Tell our audience about what transitional care planning is.
So transitional care planning is planning across systems and across models of care. So for example, being discharged from a hospital to home, or being discharged from a hospital to an acute rehab center. Beginning very early on to look at what are the needs of this patient, the family, involving the patient and family in the decision making, not springing discharge decisions on people at the day before discharge, for example. Making sure medications are reconciled, making sure there is sufficient support and education for care at home. So transitioning, and that's where so many errors occur and rehospitalizations then become necessary when plans are not thoughtfully made. And the IOM, the Institute of Medicine, has coined the phrase continuous healing model rather than these sort of episodic care events. So looking at person's trajectory over their illness journey and making sure these transitions are as well planned, well supported, and well communicated as possible to avoid errors and problems.
Well, I think that sounds very good, but I think for the most part, a lot of this is invisible to the average person. So what it is now, I mean, people, if they are discharged and they have a good experience, they go home and everything works out fine, they never think about it again necessarily. But when it doesn't go well, like the medications have not been reviewed, or they really don't know when they get home, what is the next step? Are you saying that this will be more visible because it will have a better resolution, a better outcome? What are people going to see that's different?
Well, what I can say is your viewers have to take an active role. They have to be their own best advocate, and they have to ensure that the day of admission in a hospital, discharge planning ought to begin to occur. Who's their case manager? Who's their social worker? Begin to talk about discharge planning. What are the needs going forward? And the family and the patient has to be actively involved in that process.
So are you suggesting that the patients start asking those questions right from the beginning?
And if they're too ill to ask those questions, then a family member or a significant other has to ask those questions. What is the prognosis? What impact on their quality of life and independent living is this illness going to have? What sorts of supports do we need to have in the home? What level of care do you as physician, do you as medical team recommend? And then the family has enough time to talk very thoughtfully through, can we provide that level of care? What services do we need to introduce into the home? Or is a skilled nursing facility, perhaps, or an acute rehab center, the best venue for discharge, at least temporarily, until we can get all of these services in place?
Well, now that sounds very good, but I'm just interested in Connie's view on this. most people go into a hospital often overwhelmed.
Yes.
You know, they don't want to be there. Secondly, they don't know what's going to happen. Thirdly, I think we're used to having other people direct us and tell us what's coming next versus being, what you're saying, a dynamic participant.
Right.
Connie, how do you see people making that transition?
Well, I'll tell you, we all know, particularly as psychiatric nurses, that when you are ill, you have a tendency to regress. So it's really asking the patient, a lot of the patient, in a day when you come in and you go out very fast. So I really think the opportunity is for nursing. And the reason for that is because it's the nurse that's going to coordinate the care. Okay, so then you think about what empowers a nurse to be the coordinator of care. Because that's really stepping over certain boundaries, isn't it? All right. Quick example, if a patient isn't cared for properly before they go into the operating room, right, then, or something happens where the care isn't given prior to the surgery, it backs up the whole operating room schedule, doesn't it?
Right.
Okay, so the legitimization of the nurse as the coordinator of care means that, for example, information systems have to be developed that would put the role, the power of that role in the nurse. And I'm very optimistic about that because I do see that nurses, because of the 24-hour clock, have the best opportunity to take on that coordinating role. It's a talking role, Nancy. It's a speaking role. It's listening.
Right.
Okay? And nurses are well educated to do that. And so I think that nurses have to let patients know that they will take on that coordinating role. And I guess what we're trying to say is patients should know that nurses have the ability to do that.
Right, and that I think that's a very good point, Connie, because again, in traditional roles, people would tend to think that their physician would be the discharge agent, so to speak. Now, the physician does write the order for discharge, but all the nuts and bolts is what we're talking about have to do with who's going to make sure that that person is transitioned properly, effectively, and that, number one, they don't come back. Not only because hospitals are really going to be penalized financially for that, but who wants to come back? I mean, once you're out, you want to stay out, hopefully permanently. But at least for the first 30, 60 days, you want to get stabilized. You may have to come back for some repeat testing or for visits, but that's different than being rehospitalized for the same condition because something didn't get organized and the discharge did not go very well. So therefore you're coming back because of things as simple sometimes as not knowing what your diet regime should have been, or you don't know what your medication regime really had to be because it changed and someone didn't really even tell you about that. So I think a lot of healthcare systems are looking at this because it's really one of the key variables in what's changing in healthcare. And I think for our viewers, what I'd like you to say is give them the lines that they should say. What should our viewers say when they see their doctor or their team to get this process going?
I need to know what's happening. I need information, and I might not be in particularly good shape to get that information, but my son, my daughter, my husband, somebody needs to have that information because I have to allow myself to be sick.
Right.
So, but the system, my system, needs that information.
Okay, that's a good line. All right.
Okay, so asking the physician, the nurse, the team, what do I need to know? What do I need to know about my disease, about the impact of my disease, about the management of my disease? What do I need to know to be independent in its management? What is the critical information? And then help me understand, Am I safe to go home and live independently? Do you recommend that I have assistance at home? And so asking the healthcare team, and I think any strong healthcare team would provide this information. Well, we think you do need 24/7 assistance, at least for the first week. You ought to be able then to become more independent, and so on and so forth. So asking those questions, and then also sitting down and having a medication reconciliation. What medications have changed since I've been in the hospital? And then asking questions. What are the side effects? Why did that medication change? How long do you think I need to be on that medication? Then, when should I call you, doctor? What kinds of complications, what kinds of symptoms ought I look for?
Right.
And then how best to reach you quickly if it's an emergency situation. When should I call?
Well, that is very, very solid. Very good advice. I think people do need those scripts in order to know, how to proceed, how to sort of break through some of these barriers. And so I really want to thank our guests today, Connie Carina and Arlene Holden, because I think that they have given us some of the really tools that we can use and you can use with your family if indeed you need to have a dialogue about your discharge planning and how you're going to be successful in coming home. Thank you very much for joining us. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening and join us again. And remember, with health, all things are possible.